Fear stops us from achieving our true greatness. Are you a professional woman who is feeling stuck, unmotivated, or burned out? Are you worried about your wellness? Are you letting fear stop you from crushing your goals? If you answered yes to any or all of these, then this is the podcast for you. Dr. Charmaine Gregory, night shift emergency physician, burnout thriver, and wellness champion, along with everyday heroes just like you, will explore how to face fear in our lives and emerge victoriously.
Hello, 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 Fearless Freedom fans. Oh my gosh, it is so exciting. We have had such a lovely build up to this particular live, and it is such an important topic. It is something that we really have to have in the fore of our minds because it impacts so many of us. And I am just beyond excited to have an amazing panel of experts here with me to talk about this topic. And we have Dr. Nicole Rochester, we have Dr. Jacinta Elder, and we have Dr. Jessica Isom. So, oh my gosh, it's going to be on and popping. We are going to get deep and we are going to have a fantastic discussion. So, Dr. Rochester, do you mind introducing yourself to the Fearless Freedom Tribe? Just let them know who you are and what you are up to.
Sure. So I'm Dr. Nicole Rochester. I am a board certified pediatrician and an independent health advocate, the CEO of Your GPS Doc. I left clinical medicine about 3 years ago to launch my company after caring for my late father. And the mission of my company is to help patients and their family caregivers navigate the healthcare system. I also do a lot of speaking and consulting in the health equity space, and I've been doing a lot of work recently related to coronavirus vaccine hesitancy. And I'm really excited to be here with you, Dr. Charmaine, and with my co-panelists. So thanks so much for the invitation.
Awesome. Dr. Elder, can you share with us what you're up to and who you are?
Sure. I'm Dr. Jacinta Elder. I'm board certified internal medicine, currently practicing geriatrics. And I basically an advocate, a health advocate for my patients, for my family and friends, for myself. And I think this is an important topic to discuss because I've seen versions of this play out over the many years I've been in practice in several different environments. I am the new CEO of a health and wellness company with focus on nutrition and mindset because I believe prevention is worth more than cure.
Absolutely. And Dr. Isom, do you mind talking about who you are and all the awesome things that you're up to?
Yes. So I'm Dr. Isom, and I'm a board certified psychiatrist that's currently working in Boston, Massachusetts at a federally qualified health center. I also am a clinical instructor at Yale in the Department of Psychiatry, and I do teaching there of residents around social justice and health equity. And I also do lots of talks and now newly doing consulting around medical racism and what anti-racism could look like as a solution to those problems, much of which we will talk about with the story of Dr. Susan Moore. So happy to be here with you all.
Awesome. Now, we are definitely going to be broaching some topics that may be uncomfortable for some individuals. I appreciate you if you have taken the moment to take a listen, to educate yourself about such things, because this is not something that's easy to talk about. For us, it's not easy to talk about, and it also is not easy to talk about because of the implications that some of the individuals that took part in the story, the kind of things that they were doing are very, very unsettling. So let's just get into talking about what actually happened. What happened to Dr. Moore? So Dr. Moore was unfortunately had gotten infected with COVID-19, and she basically had an opportunity to document her journey as she was being cared for. And this was not, by choice. I mean, she did this because she wanted to raise awareness about the situation. And unfortunately, she was not treated in a very fair manner. And she also was not treated in a dignified manner. Her pain was not addressed. And she truly had pain because she had underlying problem that was causing her a lot of pain. And, it got to the point where she actually did not end up getting the pain medication that she needed until after it was proven that she actually had something wrong with her. And there were several other things that occurred during the episode that are very heartbreaking, because she is a physician and the individual that was caring for her also knew that and still treated her in this fashion. And so it's very scary, because it speaks to what happens to somebody who doesn't have an advocate like you, Dr. Rochester, in their corner to really make sure that they're getting the care that they need. And, it also brings up a lot of memories for people of color. Now, I'm originally from Jamaica, so I don't know like all of the things that are all the history behind this, but I did end up educating myself on some of the instances where African Americans were actually treated very improperly and taken advantage of by the House of Medicine. So I totally understand why there is some distrust and why there is, this kind of behavior. It just strikes a very deep chord, because it's like a resurgence of that basic untoward type of attitude or untoward type of presentation that is happening by this physician. And it is completely against what we took a promise in the Hippocratic Oath to basically uphold. So yeah, I am definitely interested in hearing, your thoughts on this situation and why this has happened, how we can make it different, all of that. Super excited to hear.
Mm-hmm.
I don't know who wants to tackle it first.
Oh, Dr. Isom, go.
Yeah, I mean, it's interesting. It's sort of like the question for me is not necessarily why. I think the question is why if you don't know the history. But knowing the history, it's sort of like, yes, this is another example of this happening. And when I say this happening, the words that I use are medical racism. And that's a way of owning the reality of what happens when people of color, specifically Black people, access the medical system. That's what they're faced with. For Dr. Moore's story, I mean, I'll say, just to be frank, when I first heard the story, I went to go watch the video and I could not finish it. I still haven't finished it. I made it.
Yes, it's hard to watch. It's super hard to watch.
Yeah.
No, I can't. I at some point maybe I'll go, but I started crying, and I was crying for a long time after it happened, because it was just too much in lots of different ways. So I just want to honor the fact that even her information, it can be traumatizing for people who themselves could be Dr. Moore, right? Because in that moment, she was just a Black woman laying in a bed with hospital Johnnies on. So though she had the title of doctor, all they could see was her race and her gender and her size in that clinical encounter. So one of the things that we talk about is, or that I talk about, is how stereotyping and biases influence how doctors and nurses and other healthcare professionals see people, how it distorts their lens, and can lead to like the consequences of, this kind of situation where they weren't seeing her humanity. And I say that as a thing that, we all are capable of, dehumanizing others. It's not just something specific to this group of people, but the consequences of dehumanization are reduced empathy, and you don't treat people as if their full humanity is there. So her saying she's in pain, for example, and that not being responded to for me, hearing that, that's evidence that she was being dehumanized and not really regarded in, her full humanity. So that was some of the consequences. And unfortunately for Black people, one of the components of anti-Black racism is dehumanization. So that is something we have to face. So I'll just put that out there, and I would love to hear from the other two, like what your thoughts are.
I completely agree with the dehumanization. I just gave a talk this morning about medical racism in the context of vaccine hesitancy and mistrust. And, we talked about the studies that have been done. And most recently, there was a study, I think it was in 2015 or 2016, where they interviewed, white medical students and residents. And basically they listed a host of inaccurate facts about Black people, one of which was, our skin is thicker and therefore we don't feel pain. And in 2015, a large majority of these medical students and residents, they said that information was true. They believed to a large extent that a variety of those false statements were true. And then they had them rate the pain of a mock Black patient and a mock white patient, and then recommend treatment for these mock Black and white patients with pain. And they showed over and over again that those that endorsed those false beliefs, didn't rate their pain as accurately and didn't make accurate or appropriate recommendations to treat their pain.
Please continue.
Yeah, that's okay. So I was just talking about this paper that showed that even in 2015, white medical students and residents endorsed some of the beliefs that were put forth by slave owners and physicians back in the 1800s. And, these theories, these inaccurate theories still persist. And we know that there have been studies that have shown that even my babies, like the pediatric patients with documented appendicitis and extremity fractures, are not treated adequately for their pain. And sickle cell is a whole nother discussion. So, I agree with Dr. Isom that clearly there's evidence throughout medicine, even today, that Black people continue to be not believed. We continue to be dismissed. We continue to be dehumanized. And I think what disturbed me the most about Dr. Moore's case is being a health advocate, like being someone who actually left medicine to be an advocate for other people. And I constantly talk to my friends and my family members and my clients, and on social media, I'm always talking about the importance and the value of being a strong advocate for yourself, and how in many cases that makes a difference and how you get better care. And so to see this Black female physician who was, you can't be a better advocate, and she documented this on social media.
Yes.
And
yes.
like Dr. Isom said, they knew that she was a physician, and to see her advocacy efforts fail and for her to die, it honestly made me rethink what I'm doing. It's like, wait a minute, does this not even matter? So I was and continue to be heartbroken over this story. I'm hoping I can get through this without crying. Mm-hmm. Really.
Yeah.
And I'll just add, I agree with my colleagues 100%. It's a very unfortunate case. She represents so many of us who have gone through the system on both sides, right? As a clinician and as a patient and as a family member. It's just so important to address this once and for all. And the dehumanization of people of color, is where we started. And it hasn't changed that much, as evident with the political climate right now. Sure, we've had times of relative quiet, but it doesn't mean that things have changed. And I think with COVID and with all the death we witnessed on camera last year, including that of Dr. Moore, it is really time. It's really time to address this. I don't know how you teach empathy. Empathy as a way of being. You can't legislate it. You can't create policies to, help people develop empathy. But what I think we can do, in addition to having the institution where this unfortunate story happened, in addition to having them be more accountable for what happened, I think on a national level, even though you can't legislate empathy, I think there has to be policies put in place where, these things are mandated. You almost have to mandate a bedside manner. Almost. You
Wow.
can't legislate
Wow.
them.
Yeah,
but you
yeah.
mandate.
But it's funny because like, and I hear what you're saying, but it's like, how, you hit the nail on the head. Like, how do you teach empathy? Like, that is something that you would hope that we would all kind of have coming into this, because our field is one that is basically all about altruism, all about helping other people. And so it's very disturbing that you have to actually teach something like that, because that's a difficult thing to teach. Someone
Yes.
to have that emotion. So yeah, I'd be interesting how you would be able to mandate that. Would you do
I mean,
coaching? Would you do, like, how would we do that?
I think it's beyond empathy, though. I mean, what we're really talking about is people who hold implicit and explicit biases. And, there's a lot of research about the implicit bias part. We don't like to think that doctors or nurses or any other healthcare professionals are racist, but, we know that the healthcare profession is just a microcosm, right, of our bigger society. And so if we know that there are police officers that don't like Black people, and now we're seeing, with social media and people being outed, we're finding that teachers and, people in many other professions where they are expected to care and to be empathetic, we're seeing that those very people, some of them are, engaged in some of these questionable activities and are in some of these white supremacist organizations. And so I think, while it is hurtful, we shouldn't necessarily be surprised that there are people in the medical profession who don't like Black people, and maybe who were raised to have certain views and opinions about people of color. And so the real question for me is, how do we screen for that? How do we uncover those biases? I mean, I think from a policy level, I think that every institution needs to take a close look at their health outcomes based on race and ethnicity. And I think as soon as they do that, it'll be undeniable that every institution has disparities. And then that's they can be penalized based on that. And there can be correction plans, just like when JCO comes, or Joint Commission, when they come to your institution and they discover that you don't meet certain qualifications, then, there are penalties for that. And then there's a plan put in place, and you have to demonstrate that you have corrected those deficiencies. We've never had anything like that when it comes to health disparities. And I think that now is the time.
Wow.
Yeah.
No.
There could be an equity focus for JCO. And I'm not like 100% familiar with JCO and their scope, but some kind of equity accountability would be helpful. I mean, I would say I'm a psychiatrist, so the piece of medical racism that is attractive to me as a point of intervention is the relationship between the physician or the nurse or whomever and the patient, and how vulnerable that relationship is to absorbed racism that we all have absorbed, like these internalized representations of Black people that are just not accurate in other. Right. So there's stuff there that I think could be intervened upon. Like I came upon this book last year called Compassionomics, I believe. And I actually accessed that book to get a better sense of how something like empathy could be taught. And so that was a goal. But empathy is like titrated, and you have more empathy for your in-group members. So the diversity thing basically means that there are more of one group in the field than there are of other groups, right? So then there's an experience that people receive because they are a similar group that other of us can't access. And it's just a natural part of human behavior. If you're a member of my in-group, whether it be by race, gender, class, or anything, I'm naturally more inclined to be more empathetic towards you, more connected with you, more able to see you accurately. So because we're a majority a workforce that's white, and then the second largest demographic group are those of Asian descent, working with a very browned patient population. Most people are in interracial physician-patient or nurse-patient or whatever else patient relationships. So that is compounded by the fact that we live in a racially segregated society. So we don't have intimate relationships with racial others, right? And that's another source of empathy is I'm dating someone, I'm married to them, my children are, my best friend Bob down the street is. Those intimate relationships are where we get empathy from for out-group members. So if you have people who are racially segregated, going into medical school, not having any intimate relationships with all of these people that will ultimately become their patients, that's, I think, this is my hypothesis, where the empathy problem comes from. And the intervention for screening could be, you can't be a doctor unless you have a capacity for forming intimate relationships with all people, right?
Wow.
Wow, that's like amazing. How would you test that? How would you how would you identify that?
Ask questions, right? Like we screen people heavily when they're trying to get into medical school, and we measure like their grades and their extracurriculars. What if one of the metrics was like relationships? Like, what relationships have you formed with people who are different from you, specifically racial others? And like, if that was something that was required to get into medical school, maybe that's a strategy or a solution.
People would just lie, like, "Oh yeah, my best friend is Black." Like,
I know, it's not perfect. It's not perfect.
I love that though, Dr. Isom.
But you know, I do think
yes, that's awesome.
It's not going to be a perfect tool, but I do think there's something to be said about these personality type questionnaires, because they ask the question in like the same question 10 different ways, and so they come up with, you know, a summary of characteristics that actually could work. And I agree that measuring outcomes is another imperfect tool, but another tool that can be used, because out in the community, I worked for a managed care company, and which is sort of rapidly expanding now. But when I first started with them a few years ago, they did not take surveys, you know, patient surveys of how, you know, they were treated and things like that. In the last couple of years, they started doing that and reporting our NPS scores and stuff like that. And I've watched colleagues really actually have to develop a bedside manner because their scores depended on it. It's not the way you want to develop, you know, just a natural compassion for people. But when your paycheck is involved, they'll do it. You know, it's unfortunate, but they'll do it. So I've watched, you know, I've literally colleagues who sit beside me, you know, NPS scores go from like 75% to like 85% in a few months, because, you know, this is now one of the metrics that we're going to use to measure your patient outcomes, which directly impacts your bottom line, right? So now we're going to do it. So, you know, you have to attach money to things sometimes, but before I left that job, I did see that patients were a little bit happier, let's say. Before they instituted the surveys, a lot of patients transferred to me because I was their color. I was their, you know, the only female. They knew that I understood. They did not speak kindly of colleagues. It really does happen, and it's very sad. Yeah. Those two tools.
We think that everyone is good people, but most people's behaviors are driven by rewards and penalties.
Yeah.
You know, it is what it is. And we don't have rewards or penalties that I know of for medical racism. And we need both. So
I agree. 100%. 100% agree.
So while we can't, I'm sorry, go ahead.
Oh, I was just going to say, Dr. Elder, that in the example you gave, I don't know if you had a chance to observe him, but do you feel like his behavior truly changed? I mean, did he really transform, or was he just kind of doing whatever he felt like would make the patient think that he had? And maybe it doesn't matter, but I don't know. Like, how do you?
To me, it does, because I still ended up exiting, right? And because I felt like this wasn't heartfelt. This was, I'm just whatever I need to do to win.
Wow. Game in
you-
the system.
Yeah.
And me watching that as a person on the other side who has gone through some things, that still hurts.
Absolutely.
So, not a perfect answer, but it did help, because now, he's make sure you put a 10, and this sort of thing. And it engenders, I don't know, some tactics that are not in integrity sometimes. Let's just put it that way. When you're measured by the numbers, and it's a numbers game. It's unfortunate. It has become a numbers game, the practice. So there are a lot of things to look at, and I'm sure with growing awareness and more discussion, maybe there are more ideas that will come forth that will help to bring some things that can resolve some of these issues. But it's unfortunate a lot of people have to die first. I mean, we lost over 400,000 people because of lack of empathy and leadership, right? So, yeah, it really does matter.
Wow. Yeah, that's real. That is for sure. You know, the other thing that has been brought up by the audience, Dr. Chrissy B basically is asking that she saw that there's a recent article that mentioned how 80% of nurse practitioners are Caucasian women. And in many cases, they're working in the larger cities with high minority populations as well. So will the empathy test be attached to nurse practitioner education as well? So, because now we're having to think about like what is happening with the expansion of coverage to get to our people, and so how is that going to work? Like, how are we going to maneuver that?
That's a great question. I mean, I think it would have to, I mean, anybody who is taking care of patients needs to be measured in this way. I think the health equity lens has to go across the entire organization. So, I mean, that's a really good point. I didn't know that statistic, 80%. Wow.
Yeah.
That's a lot. Oh my gosh.
Yeah.
But when you think about it, I mean, there are only 3 to 5% African American physicians across the country. So, and we're about 13% of the population, I believe. So definitely represented. That's another thing. I mean, in terms of medical school and recruiting underserved minorities might be another way to expand some of this.
Yeah, I just posted, there's an article that was written by some colleagues from Yale. It's called Blackface in White Space, Using Admissions to Address Racism in Medical Education. That is one that talks about what we're talking about, which is like what admissions criteria could be used, including like surveys and things like that, to determine what kind of beliefs people have. I'll say this. No person in medical school should believe in colorblind racial ideology. You're not allowed to
say it again.
Right, because people don't want to admit it. They don't want to admit it.
Yeah, I'm sick of these people, right? And we can't even get to like the solution part because we're trying to convince people racism is real. So that's one. There are colorblind racial ideology scales out there that could be administered. And bring these people out. Like, you can't be a healthcare professional if you don't believe racism is real. So that's one easy one.
Yeah.
Wow.
Yeah.
Yes.
that was a truth bomb right there. Like,
exactly. I almost fell out of my chair on that one. That is my biggest pet peeve ever.
Oh my goodness.
I'd rather you tell me that you don't like Black people than to tell me that you don't see color. Oh my God.
Right. Because how is that? Are you blind? Everybody sees it. You got to see that.
Yeah,
I agree.
But those folks usually tend towards the non-contact sort of specialties, so like radiology, which we still need them, that kind of thing, and not so much of the bedside stuff like we do. So maybe it can be used to guide them in terms of which specialty. I don't know,
because there's another thing too here, y'all, which is that so what you were talking about earlier with people believing that Black people's skin is thicker and
Mhm.
our nerves are less sensitive. That's like mythology. That's like imaginary things about biological racial difference that is the core of medicine. So
Right.
that's
Yeah.
the core of medicine that we still have yet to address. Nobody wants to talk about that, even though it's 2021.
Yeah.
But all of that is like operating here, right? And we're all absorbing that here. And that's something that we still haven't addressed in even how we teach, like people who are coming along and then people who are treating people now. So one big thing that's happening right now is like, okay, well, let's talk about biological race explicitly. And let's look at how we use it in these algorithms to determine what kind of care people access.
Absolutely.
So there's a paper in the New England Journal of Medicine called Hidden in Plain Sight, which goes through a number of different specialties like cardiology, nephrology, obstetrics, gynecology, and says, hey, you're using a race correction factor in this algorithm, right? And if race is a factor, that means that you believe in biological race, which is racist, right? And like, what are the equity outcomes of you deciding that my race is biological? So am I having less access to kidney transplants? Are you choosing me for a C-section instead of a vaginal birth because there's a race factor in that algorithm?
Yeah.
Like that is a conversation we could also have right now about those manifestations of medical racism.
Yeah, because artificial intelligence is being used to run those algorithms, and they're going to take it and run with it. You know what I mean? So it's really
scary.
I mean, basically, it requires a complete dismantling of healthcare and medical education as we know it. Who's really? I mean, I hate to be a pessimist, but who's about to do that?
Well,
and are we? We're never going to have. I shouldn't say never, but I think it won't be in my lifetime that we have 50%, 60% Black and brown physicians, nurse practitioners. So it's like, what do we do in the meantime? I mean, I guess we just have to take it one bite at a time, but it's discouraging.
Yeah. Well, it's like you said earlier, healthcare is a microcosm of a macrocosm, right? So it's about dismantling the system, period. And then we squeeze in there some kind of way, you know what I mean? So it's a whole system. How do you do that? In terms of political agenda, we have a 50% diverse cabinet now. Maybe that will help trickle down. I don't know. But, as above, so below. So it's got to start somewhere.
I agree. And I don't even know how much, I don't even know. So it's like, so one thing I'll say is one thing that we could dismantle starting off is white supremacy culture, because that prevents us from even having the conversation. I'm whispering white supremacy for like all of my career until last year. Last year, I finally started saying white supremacy culture in my talks because it felt like I might get like attacked or something if I said the truth, right? We could start talking about that. And then one part of that is like, I think about power and who holds it and how tightly it's held and how cultural that is. So that this power hoarding thing is like a white supremacy culture thing, which is why you and us, right? We are prevented from accessing that power and influence that could actually allow us to make these changes. So like the cultural shift might be a place to start.
Definitely. And, there's the supremacy and then there's the privilege, right? And it's like a spectrum. So I heard a pretty interesting discussion earlier today. It's never really going to go away, but the key, which you brought up, is a good one. It's about who's holding the keys, right? So is it that you push it back to the fringe so that it's not center power? You know what I mean? Because it's always there, so that it doesn't gain momentum. I don't know. But then you still have, people who are going to ascribe to this sort of philosophy or ideology. And then the privilege is just some folks walk around, they don't even know they have it.
Right.
Yeah. Because they want to say, I didn't grow up rich either.
Yeah, but
my family was poor. Okay.
Yeah.
That's a lot. That's a lot.
One of the things that I've been thinking a lot about, going back to Dr. Moore for a moment, and is that, we how many more Dr. Moores have there been? You know, I mean, like we said, she publicized her trauma on social media, but there are so many Black and brown patients who are disrespected in the healthcare system, and they don't even think to file a complaint. I mean, they may go home and, you know, talk to their wife or their husband or their kids, but it ends there. And if they do go that extra step of sending an email or filling out the you know, the patient satisfaction surveys or whatever, you know, my thought is that those voices are probably silenced. There are probably things that are said to say, oh, you know, like it's not taken that seriously. And so what can we do to elevate the patient's voice in this process? So that, I mean, it's a double-edged sword, because I know as physicians, you know, you hear the criticisms about patient satisfaction surveys, and you hear the criticisms about, you know, the reviews on health grades and all of those things. And I think the tendency in the healthcare profession is to downplay the voice of the patient and to make excuses and to say, you know, oh, that patient was just angry or whatever. But if we were to really gather the collective experiences of Black and brown people as they, you know, go throughout this medical system, this healthcare system, I bet you there'd be a lot of physicians, nurses, and other healthcare professionals that, if that information was taken seriously, should be fired on the spot. You know, like some of these people are probably repeat offenders, but those stories are never told.
Right.
Yeah.
Right.
Yeah. But you know, it's
And maybe
interesting you mentioned that, Dr. Rochester, because and as you're like looking through what happened to Dr. Moore, it was stated in there that this particular individual, actually, that wasn't his first time doing that to a patient. So, you know, whether he just had something against brown people or whether he had something against women, I don't know what his deal was, but you know, clearly behavior was not on par with what is expected of someone who's caring for ill people. So yeah, you're right. So we can identify patterns a lot more easy if we were to look at, you know, look at a timeline. Like, okay, well, this was flagged. And you know, the other interesting thing about the whole patient experience issue and why it's kind of like a double-edged sword is, you know, we have, like, for example, from emergency medicine standpoint, the Press Ganey, which is based on patients who are discharged from the hospital, right? So we take care of the person and then they get discharged. Now, it could be that their experience was they were there for something very minor. It could be that they were there for something major. The thing was resolved and they got to go home. It could be that they were there for some other secondary gain and we did not meet the expectation that they had, and then they, you know, complain. So sometimes those surveys are not going to give us the information that we really are needing in order to make a change and to identify those of us who may need assistance in helping. You know, basically, this is how you repair your relationship with your patients, or this is how you identify that you are having some element of bias, and this is how you can address that. This is how you can figure out what your trigger is and then identify that thing, and then, you know, either walk away, step away, maybe give that care to a different person. Like, just really being able to take an action that's going to really benefit the patient. And so, you know, the surveys are, I guess, a good start, but I see where there can be like it's not going to be as great, or it's not going to be the halcyon that we think it's going to be, because people, you know, it's selective who gets it. And then the other thing is, you just never know, like, really the people who really should be getting it aren't the ones getting it. And so you're really not getting the true data that you need.
That's
so
true.
Yeah,
Yep.
so that's the part about it that I feel like is kind of hard, because you have to gather data. I mean, I get it, but at the same time, it's like, how are we getting that data?
Yeah, very important.
Yeah. I mean, usually it's like the entitled people, and entitlement is not something we all have access to. Like, I know my family doesn't. So like, and I was just having this conversation earlier today with one of my colleagues who was trying to help a patient complain, and the patient was hesitant to do so. And I was, this is a white person, so I was trying to frame this for them around like what our role could be. And I was like, well, we have to address internalized oppression, right? Which tells you that you're not entitled to anything. And people who are entitled or feel entitled, at least, and that's like that white privilege thing, of course they're going to complain, like, I'm entitled to good health care. That's what I'm supposed to be getting, and you're not giving it to me. Versus someone with internalized oppression, where it's like, I didn't expect it anyway. And if I were to complain, would the system even be responsive to me?
That's it.
Yeah. Or would there be retaliation? Would the doctor not want to see me? Right. So it's just thinking about your work with being a patient advocate, which I was like, oh my God, this is so amazing. One thing I would love to do if I had the time in that role would be helping to facilitate people like getting rid of that internalized oppression that prevents them from being advocates for themselves. Not because we need white saviors, right? Because we have the capacity to do it, but we just have to unlearn some of what they've been forcing down our throats about what we're deserving of, which is easier said than done.
Yeah.
Absolutely. Oh, wow.
So many layers.
I know.
So many layers. No, this is good. This is a really good thing. And the other thing that I have to say, I mean, and I don't know if this is true across the board, but like, there were a lot of things that came out of last year that were not super positive, right? I'm the first person to admit that. But there are a lot of things that, like, the chinks in the armor of the House of Medicine just got like exposed, like, like oxidized. So they're starting to rust. I mean, it just really made very clear where we have areas in which we have to work. And it's just, and that particular area, the one where we're talking about empathy and we're talking about our biases, the biases that we have so deep down inside that we don't even realize that we have, those are the ones that, it's like we're oblivious to them, right? We don't even recognize it. So for me, and I'm the first person to admit this, like, for me, my trigger is the alcoholic, right? So I get a patient in the middle of the night and they're alcoholic. That's my trigger. Like, those are the people that I have to be super careful with. I have to literally, just take a step back and say, okay, this person is alcoholic. This is my trigger. These are the people that, like, I have a deep issue with, right? They're fine people, but I'm just saying, like, in my, I don't know what it is, because I don't have anybody in my family who's alcoholic or anything like that. But like, there's something about alcoholics that rub me the wrong way. Okay. And so as I step into that room and I see that the person's alcoholic or they're there for alcoholic complaint, I have to stop and actually like reprogram my mind. And I have to say, you know what? This is a person that's a trigger for me, and I have to make sure that I provide them with excellent care. I have to make sure that I do not, like, there's no transference that's going to happen here. And I also have to make sure that I'm going to do everything as if this person was not an alcoholic. And I tell myself that. I'm like, this is not an alcoholic, and then I go into the room. And so I think that the training, like, not just the empathy, but it's really like the training that we need to have is really gonna have to dig deep into, like, what is our trigger, right? Because I mean, some people's trigger may be that they really do believe that our skin is thicker as brown people and that we don't feel pain and the needle is going to break when you put a needle in our arm, whatever it is that we believe, or that's, from our upbringing or whatever it is. But like, we have to recognize that. And I bet you the study came out of Virginia, I think, Dr. Rochester. And like, I bet you that those individuals, they had no idea that there was a problem with that ideology, that they had no idea that there was a problem with how that allowed for them to deliver medicine to the people that they're going to be caring for. And so until we actually start uncovering what our biases are truly, there's no way that we're going to be able to deliver the care that we really should be delivering. Yeah. And I honestly don't think people are, and I don't know, this Dr. Bannock, I don't think that, well, I'm hopeful. I guess I'm being very, very like hopeful that he wasn't thinking that he was going to be malignant with Dr. Moore. Maybe there was something about Dr. Moore that triggered him. Maybe it was that she was a woman. I mean, maybe he might have been somebody who felt like, what, a female physician? Like, it could have been something like that. It could very well have been the melanin in her skin. Yes, it could have been a lot of different things, but like, clearly he did not pause, recognize his trigger, and then still provide excellent care to her. So it'd be interesting to see what kind of care has he provided to other patients that he's cared for? That would be really interesting to see, because then you'd really be able to see, like, well, okay, his trigger may very well be racially based, you know? So
Yeah, I think that's an excellent point, Dr. Gregory, and it makes me think of two things. Um, Surveys from, getting surveys back. You go to Target or you go to wherever, everybody's pushing a survey. So everybody's asking for surveys. So getting surveys every time you get care, and being careful to fill them out. And if you see a pattern in a physician or a nurse practitioner or something like that, then that person should be should have, I don't know, a certain number of hours of therapy or something. You know what I'm saying? And don't just let it slide, because that's impacting their care. When I think about when Dr. Moore says, he didn't even listen to her lungs. I have to tell you honestly, I've seen that so many times. I've seen doctors run in and run out, and they don't listen.
Yeah.
Guys, come on now. This is
Yeah.
we're telling the truth now. And it's like, how could you have a patient with COVID and not listen to her lungs? You didn't even want to touch her.
Yeah.
Okay. So that's really deep. So, and I'm sure even if there's something about her that triggered him, it wasn't the first time.
Right.
Correct.
He just got caught this time.
This time. Right.
You see what I'm saying? And this is where the institution has to take this under serious study and figure out what's been the pattern here and how we're going to adjust moving forward.
Yeah. And I'm just going to say, because I think we're giving people an easy pass by making that bias inaccessible. It is accessible. Like we already know which groups we have a positive bias towards and which ones we have a negative bias towards. We have that information. Yes, based on our individual histories, there might be some textured nuance, right? Like maybe my uncle was an alcoholic and that's the reason why, just hypothetically for you, although that's not your story, that's a piece of it, right? But all the rest of it, I would say like 90%, we already know. Fat people, that's one of the biases that over time has gotten worse. I'm one of those people. So is Dr. Moore. So when a fat person walks into a healthcare setting, they're likely going to experience anti-fat bias and anti-fat discrimination, right? So both the preference and the behaviors. We know skin tone, right? So even beyond like your racial group membership, how dark your skin is going to determine a positive or negative bias towards you. Class. So we know that there are accessible things. And when you were saying your checklist, let's talk about a checklist for those accessible forms of bias, right? And then for the other 10%, go get therapy. But we have to make it accessible, because people will say, well, I don't have time for therapy. But look at this long list, right, of accessible biases that we all have trends towards in this country through things like the IAT. Those are things we could be thinking about in our checklist. And actually it should go both ways. Who are we attracted to and drawn towards? And how does that influence how we interact with those patients? And then who are we repulsed by? And how does that influence our interactions? And we should be thinking about both, because a lot of the disparities is like an in-group preference. Like you do more for people that you're similar to. You went to the same school as me. You look like my auntie. Something about that draws us in, and we do more for those patients, which could have pros and cons. But we should be talking about both. So one strategy in addition to that could be make this person your grandmother, or make this person your brother or your favorite school teacher in your mind. And that's a way of drawing you in closer to them and maybe adopting some of those behaviors that you imagine you always do with everybody. But this is a whole paper, y'all. Like everyone's like, what are we supposed to do? I'm like, like these are the strategies that we could use, some of them right now. So that's my 2 cents.
And Dr. Isom, is there, well, first let me say, Dr. Gregory, I commend you. I mean, I think the fact that you not only recognize your trigger, but you have developed a process to address it before you walk into the room. I mean, if we could just get every doctor to do that, I mean, wow. So that's amazing. But Dr. Isom, as a psychiatrist, has that been studied, what you're suggesting in terms of, if we have a checklist of these common or accessible biases? And I mean, is it really realistic that a 25, or let's say 30-year-old white man can look at me when he walks in the room and envision me as his sister? Or, you know what I mean? Like,
Yeah,
how does
yeah.
that really work in real life?
So maybe he could. Maybe he has a beautiful like imagination, but there are other ways, right? So it could be like, what is it called? There's a fancy way of saying finding similarities between you and an other makes them more of an in-group member. So you can find out, be curious, first of all, and find out something about you that's similar and that draws you in closer. So maybe you went to the same school, maybe you're from the same town, you like the same ice cream. But the interesting thing is when you're talking to your in-group member, you naturally are curious and ask those kinds of questions to find those things out, right? So in the studies where they show like interracial encounters between physicians and patients, we get less of that from white doctors. They don't smile as much. They don't ask, like, they don't lean in as closely. They don't ask questions, and they're not as curious about us. So that's another way that we don't even get the opportunity to share things that might be similar about us. So a strategy is to find something about that person that brings them closer to you. And that's another way of doing it versus like just imagining them, you know, that they're like your family member. Especially if they nothing like your grandma. But there are strategies out there that, again, like you could do that, just like you described, Dr. Gregory, before you enter into the room and while you're in the room with the patient. And judges have been like reamed for their bias in ways that we should be reamed too. So judges are in their courtroom, they have checklists. They have checklists that they have to go through to, you know, quote unquote, check their bias. We say it, but we don't all do it. So we get a lot from the criminal justice system too. And that's like in my fantasy world, something I'd like to explore more in time that I don't have. Collectively, we could learn a lot from them and start thinking about employing some of their strategies.
Wow.
No, that's awesome. That's such practical information because like those are the things that we can literally do like tomorrow or the next time we see a patient, which I think is amazing. So thank you for sharing that. Really appreciate it.
Mm-hmm.
That's very powerful.
Yeah. We get into like analysis paralysis where it's like, where are we going to start? And this is just a beautiful example of we already have ideas for what we can do. You know, we just have to try it. And I know that it would be nice to have research that says that these things that we do directly translate to outcomes. And I'm not sure who's going to do that research. Someone should, but it doesn't mean that we can't try, you know.
Yeah.
Mm-hmm.
Absolutely. Absolutely. Wow. You realize that we have had such a fantastic discussion that we have been chatting for over half an hour. Did you guys realize that?
Wow.
Yes, it's been so good. So many nuggets. Oh my gosh. Thank you. Thank you. Thank you so much. I really appreciate you all taking time out of your busy day to basically talk about this because this is something that's super important. And, you know, it's something that we just don't talk about enough, honestly. And so I appreciate you for doing this. The other thing is we have a tradition on this show. I don't know if you were aware of this. I'm sure you are, but in case you're not, I will remind you. We are going to be talking about a couple of things. Like we have fill in the blanks, and basically the fill in the blanks are surrounding fear, right? Because everything that we talked about today really comes down to fear, right? Because it is fear on the part of the patient who comes in to see a physician, and then unfortunately they may end up with somebody who has biases that are affecting their ability to deliver excellent care. It may be fear on the part of the physician where, you know, maybe you might feel as though you are afraid because you don't want to be the one who is accused of providing care that is in a biased manner. So there's just so much fear surrounding this whole discussion, and we have tapped into a lot of them, provided a lot of practical examples about how we can face those fears and emerge victoriously. So thank you for doing that. So now what I'm going to do is the three fill in the blanks are usually we do one person that does all three, but I think what we'll do today is I will have Dr. Rochester, if you don't mind. The first one is going to be to fearless freedom means, and then you fill in that blank.
Oh, I got to go first. Okay. To me, fearless freedom really means following your passion. I think if I were to just summarize it, and if I look at my life and the things that I've been able to do over the last few years that I never ever imagined, I think that's what I would say is following your passion in spite of everything that may tell you otherwise.
Awesome. 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 And Dr. Isom, can you fill in a blank? If I am fearless, I will.
If I am fearless, I will. I will say, if I am fearless, I will say my truth and not duck after. So say my truth and stand in it after, and not duck, worried about what kind of things might come my way as a result of saying my truth. So I'll
Oh
go
my
with
gosh. Oh, that's good. That's a good one. All
that.
right. Okay. And Dr. Elder, my battle cry is
I was given a spirit of courage and not one of fear. And
Love
I
it.
just learning to step into that more and more every day.
Wow.
Love
love
it.
it.
So powerful. So
Awesome.
powerful. Awesome. Wow. Thank you. Thank you. Thank you, doctors. I really appreciate you. I appreciate all that you're doing, all the awesomeness that you are putting forth into the world. And I thank you for your time, because you all are busy. And so I truly appreciate you taking time out to have this discussion and to share your expertise with the Fearless Freedom Tribe. We appreciate you.